Dr. Trehan, welcome to BW Conversations. It is a delight to have you here. Let me start with my first question to you. So how can we deliver easy access to care? If we were to say that, for patients who, let's say, need ambulatory care and not really a hospital bed. So what can the strategy be?
So, you have to actually categorize the patients in different segments. So when you are saying somebody who's ambulatory, do they require ancillary services along with the ambulatory care? So ambulatory care can be of many varieties. Now, supposing you have a person who's elderly, who's had an injury to the leg or to, having trouble walking but needs physiotherapy. Now, can you provide physiotherapy in their own location rather than having to come to the hospital for physiotherapy?
Right.
So then it happens that what physiotherapy do you need? If you need a physiotherapist to do it with minimum equipment, it can be done certainly at home and it's much more economical, much less pain, and the kind of service that should be provided. No question in my mind. Now, then the question of who will provide it. Because say like National Health Service in UK or some of the Medicare in the US, they have programs inbuilt into the senior care that they will be able to provide certain services at home. And they also find it very efficient and economical as a country to afford to give some people therapy at home rather than transport them to a hospital all the time. So that's one very clear thing that is actually not well developed in India at all. It's actually lacking. And I think we should very seriously look at it. And this is one of the things that have happened in this COVID times, that it has forced us to think of things which we were already in our thought process but were out in the distance. And now they have kind of been compressed to say, yes, progressively we can do things remotely. We can do things over IT. And so today, I'll give you an example. At Medanta, we used to do about 100 video and teleconsults a day. Today, we are doing upwards of 500, 600.
This was before COVID, you're saying?
No, before COVID, the teleconsults,
that
they were over the telephone or video, which we were doing was about 100 a day. Between all the consultants, all the senior doctors, mid-level. Today we are doing upwards of 500-600 a day. That means that today, because of the restriction on travel, people's inability to be physically present, that what we were thinking or we were doing in a small manner, we were forced to do it in a multiplied manner. So now what we are saying is, we are also recognizing that there are newer tools that have come up to be able to do the diagnostics. So we have, say, electronic stethoscope so that we can hear the sounds of the heart. We don't have to be next to the patient. We can guide the patient where to put the stethoscope. 50% of the patients will not have to physically travel to the hospital. They will not need to be touched. And we can at least do their preliminary diagnosis at home. Now, when they need a CT scan or an MRI or a sophisticated test which cannot be done, then of course they'll have to travel to the center that has these facilities. And if they need a procedure, of course they will go to the doctor of their choice. So sequentially, these are the kind of things that are come into play today.
About the increased presentation of, cardiac symptoms in patients with COVID. Could you tell us a little bit about that?
Yes. So in the very beginning of the pandemic, the understanding of the virus was much less than what it is today. So we were under the misconception that yes, of course, it affects your airway tract. It goes into the upper airway tract, multiplies for 3-4 days, then goes down into the lungs, and then starts affecting the lungs, and it destroys the tissue. And this is the mechanism in which people cannot breathe, and their oxygen exchange becomes difficult, and that's how ultimately they may or may not make it. That's the outcome of this virus, our understanding in the very first few weeks. Then something very interesting happened that in Bergamo, Italy, 50 autopsies were done. Actually, WHO had actually banned it, but they went ahead and did it anyway. And with the discovery of those 50 autopsies, we found that lungs were getting affected, but that was not the prime cause. That the lung tissue was being damaged, but what the prime cause was that this virus stimulated the body. The body started responding to try to limit the damage or fight the virus, which is what we call the cytokine response. The cytokine response would be different in different people depending on the intensity. But that cytokine storm, which was an effort of the body to fight the virus, actually produced a lot of inflammation. And the small arteries, what we call arterioles, would get clotted. The blood in them got clotted, so the oxygen exchange was not happening. So that was the main mechanism where people died. So our understanding then went on to say that yes, this inflammation is not only limited to the lungs. It affects the heart, it affects the kidneys, it affects the liver and the brain. So all major organs or targets of this kind of cytokine storm and the virus. In fact, we at Medanta did a biopsy on a patient who was post-COVID, his kidney function was not recovering. So we did a kidney biopsy and we found the remnants of the virus in the kidney. So that proving the theory that the virus doesn't limit itself to the lung, it can travel to other organs also. So anyway, what does it do to the heart? Same as we said, that if it causes the inflammation of the heart, in those people who have pre-existing cardiac disease, that may be blockages in the arteries, people who have had stents, people who have hearts have become weak from previous viral infections or other reasons, their inflammation was very serious to them, more so than if your heart was normal. And to prevent the blockages from this inflammation, the blockages in the arteries that carry the blood, we understood immediately that we should put them on blood thinners. And the most practical one is low molecular weight heparin to try to prevent this clotting happening in the body. So three things happen. One, pre-existing heart disease becomes worse. That means somebody's had a bypass, somebody's had a stent, and that clots. So it becomes worse. Somebody gets a major heart attack. Second thing is that the heart muscle starts getting weak because of the inflamed tissue. And the third thing that happens is the nerves that regulate the heart's speed and its rhythm, they get affected. So if they get affected, then you have what we call tachycardia or arrhythmias, irregular heartbeat. So that's what the three-pronged danger is to an individual. What we found, young people who are pretty healthy in the sense of active and exercising, that kind of personality, they had very mild case of COVID, breezed through it, but when they went back into exercising, that they had major problems. I mean, I know 4 people who dropped dead because of this irregular heartbeat. So that's when we started studying this syndrome. That's what we call the post-COVID syndrome. In post-COVID syndrome, what we found was that let us assess what damage was done to what organ. Not just say, you're well now, you're negative, please go back. Because that's what we were doing. We are doing people, if you're fine now, your oxygenation is okay, your COVID is negative, you can go back and gradually go into real life. Not knowing that what damage has it left them with and what will it do in the future. So now we have developed a full program of saying, let us test those 4 vital organs that we talked about.
Yeah.
So we said lungs, of course, because oxygenation depends on that. Heart, because your life depends on it. Kidneys, also because if they get packed up, you can get into serious trouble. Liver and brain, okay, which are the least affected by it. Okay. So now we say to people who you want to go back into real life and especially be very active and even exercise, you should have a full assessment before you turn yourself loose.
So I have two questions. First is that over a period of time, over the last few years, do you think that, in regards to cardiac disease, has it gone down in India, or do you see that the demographic has shifted, changed? Has it gone up? That's number one. And number two is, how do we make sure that, preventive cardiac care can be made accessible to masses?
So the first answer to the first question is that, it's not going down, it's getting worse. We are seeing more and more younger people getting it at an early age than we did before. And as it is, in India, the affliction is about 10 years before the affliction that occurs in the Western population. So there are multiple factors which we believe, including genetics, our habits, smoking, sedentary lifestyles, all these things, and rich food. These are all things put together make us more vulnerable. Okay, so we are saying already, notice that it is occurring 10 years earlier than the Western population. But now what we are seeing as time has gone by, and I've been back to this country I was in the US for 20 years, I've been back for now almost 30 years. And I've seen the whole scenario getting worse, not better. Now, look, our understanding of the disease is better. Our communication to the general public is better. In spite of that, I said what I said. Now, what is the communication to the general public? We have spelled out for you several risk factors which do affect the heart. The first major one being what we say, know your genes. Because if you have heart disease in your family, there is double the chance that children will get it than the general population which does not have heart disease in the family. So it's one double value. Second, if you are a smoker and you have a already history in the family, then you even double the chances again. And then if you're obese, diabetic, and careless about your cholesterol levels and all that, then doubles it again. So we know that if you have a certain set of pre-existing problems, and those are heart disease in the family, diabetes in the family, or history of high blood pressure. To add it on, if you have a highly stressed job, that by itself will give you a problem, right? So the basic thing is that if you understand these factors that is the first step you can take, is to go and get yourself checked by the age of 30 to know whether you have these risk factors or not. And then you neutralize these risk factors. So if you are able to control them, you will reduce the incidence of heart disease in you as you progress.
When they come in with, say, one particular problem, should they be treated by a team, or should they go to various specialists for their care and treatment? That is one. And the second is, I want to know, what are the lessons that you would say we have learned from COVID-19?
So, as far as multi-organ or multifactorial problems that a person may have, generally, if, say, you have a cardiac patient and you have 2-3 other things attached to it. Today, we have made programs which looks at it comprehensively. So we say there is such a thing as executive health check, which will concentrate on your major or pre-existing disease, but everything around it also.
Yeah.
You can have a healthy heart check. Healthy heart check means that you know that you have family history, you have diabetes, possible tendency, you have high cholesterol. So all that is under one program in one stop. So these are programs that we have created with exactly in view what the question you asked. That you don't want one person to be going to 10 different doctors and one doesn't know what the other said. So it's better to have a well-rounded 360-degree program for an individual. Okay, now you say, I have like 1, diabetes, 2, I have, in addition to that, arthritis. Now that is not the daily occurring problems. It happens often enough, but not like you. So in those situations, you need to see the specialist on both separately. 1, they may or may not be connected. 2, there are super specialties which cannot be dealing with patients because it doesn't happen together. So that's one of the things that we have to understand the difference. But it's overall, if one wants a good, healthy living, it's better to have one global program for you. Starting early, that means by 30 years of age. Supposing I see somebody who's 30 years of age, had some, we know all their risk factors, we do the appropriate tests and we find everything is fine. Then we will advise them that, look, you, given your history, given what we have found, your next checkup will be 3 years from now. Or you have no history, nothing, you're 25, 26 years of age, let's do it 5 years later. So you can customize it for the individual. And that is the benefit of these programs, which are global, which are inclusive of everything. One, they become cheaper also. So not only do you save time, you'll save a lot of money and you get better advice. So like we did, we have a wellness center. At Medanta, we have a full-blown wellness center, which has every possible part of your body can be checked there, including your muscle strength, your walk, your gait, your prediction. So what we do is we call it the predictive health model. The second part of your question.
Lessons that we have learned for healthcare,
So the first thing is, it is, loosely called as the new normal. And the new normal is for everybody and every field. So what have we learned? First rude shock that comes from a general point of view is that we thought it was going to be 2 to 3 months and we'll be okay. Today we are sitting 7, 8 months and we still don't know when it's going to end. So that is the first learning, that there is no predicting about this virus. So if that be so, you also learn that there's no point taking liberty with the virus, and your new normal will be that you will be self-protected.
Well, at the moment, we all just want the pandemic to completely get over and go away, but it just, the spike and everything, and every country is sort of seeing it come back almost.
So it tells you that you're not so powerful that you can actually rule your future, that there are forces which are much higher than human beings, which can work havoc on you anytime.
So thank you so much. Thank you very much for your time.
Okay, good. Nice knowing you, and thank you.